Right. So, good evening, everybody. So, welcome to this INICET Predictor series. So, I'm Dr. Srinath. I'll be taking you through two important topics of medicine, nephrology and rheumatology.
Okay.
Hormonal defects in CKD, of acute kidney disease, and finally, some points about the management of CKD. In rheumatology, needless to say, important remains the lupus disease, especially SLE, the inflammatory arthritis, both RA, SPA, as well as gout are important, and the group of vasculitis syndrome. So today I have taken few questions, 15 questions to be precise, to discuss with all of you. The important point is not just about arriving at the answer, but also understanding the reason for the answer. Okay, that is what we want to do. So, one by one, let us take it forward. When a 30-year-old patient, when a 30-year-old patient right. So the score that we are expecting in this test, the score that we are expecting in the test, yeah, just rejoin and you will be fine. Yeah. So in this test, I am expecting all of you to score at least 12. Okay. So let us go through them. When a 30-year-old patient presents with recurrent kidney stones, the metabolic acidosis, and the normal anion gap, what is the type of renal tubular acidosis is most likely? So correct, very good. So we know that we are having the type 1 or the distal RTA. The key word being the recurrent renal stone. So we said that the first step when the patient is having the normal anion gap metabolic acidosis, one of the cause is the RTA. One of the rare cause are the RTAs. Cause are the renal tubular acidosis, which can be divided into the four types. So among the four types, if I have to tell you that what are the key points. So yes, Dr. Aishwarya says that isn't it less than 10 years. So we have mentioned in the class that the 30% of the type 1 RTA can be adult onset or acquired also. So it is right that majority are going to be inherited, but there can be 30% which may be associated with the autoimmune disease or associated with drugs like amphotericin B. So this is exactly what we have discussed, that sometime we may not be asked what is the typical presentation, but a different presentation. However, even if you say that it is a case of RTA, the type 1 RTA is the one which is going to present with the recurrent renal calculi, presenting with the recurrent renal calculi, and the diagnostic test would be the urine pH more than 5.5 will be diagnostic of the disease. Yes, if the patient was having the type 2 RTA, the clue would have been presence of the Fanconi's triad. The presence of the Fanconi's triad, which includes the glycosuria, the amino acid urea, and the phosphate urea, would have been the right answer in this question. For the type 4, that is hyperkalemic RTA, the main feature would have been, as already mentioned, is the hyperkalemia, is characteristic of the disease. No other RTA comes with the hyperkalemia. And in the mixed type or the type 3, we are looking at the osteopetrosis, marble bone, and the presence of cerebral calcification. That will help us identify the type of the RTA. So we can expect clinical questions in the cases of RTA and renal tubular acidosis. So please be open to the question. The epidemiology alone may not be the only deciding factor, but more it will be the characteristic feature which is mentioned in the exam. Excellent. So 12 out of 15, Dr. MS, that is great. So I'm very happy. So let us move on to question number 2. In question number 2, all of the feature can be used to differentiate between the Barter's syndrome and the Gitelman's syndrome, except for. So whenever exception based question comes, we want to look at what are the features which will be present in the Barter's as compared to the Gitelman's syndrome. So it should be present in Barter but not present in the Gitelman syndrome. And that can be used to identify or differentiate between the two. Whatever is first disease, that option must be present. And it should not be present in the Gitelman syndrome, right? So deafness is a very much character of the Barter's syndrome because it is due to defect in the sodium potassium 2 chloride ATPase pump defect, where it is also present in the cochlea. It is present in the cochlea also. So deafness is a very important and a characteristic feature of the Barter's syndrome, while deafness does not occur in the patient with Gitelman syndrome. The second one also is the hypercalciuria, right? Very good, everybody. Hypercalciuria also occurs in Barter with increased risk of renal calculi due to the presence of paracellular defect. Due to the presence of paracellular defect, which again is not a feature. Here there is loss of magnesium, loss in the urine. Comparatively, there is a magnesium loss in the urine, but hypotension is a property of both of them. That is why cannot be used, because both the syndrome have got diuresis, have got the sodium reabsorption defect leading to diuresis and hypotension, leading to diuresis and the dehydration, which can cause hypotension in both of them. While NSAID responsiveness, again, majority of the Barter's syndrome have elevated prostaglandin level, and that is why it is responsive to NSAID, while it has got no role in patient with Gitelman syndrome. You can also add is the presence of the polyhydroamnios. The presence of the polyhydroamnios also is relatively typical of Barter because it is relatively more severe defect. while most patient with the Gitelman syndrome will be born normally and eventually develop the symptoms of the disease. So, as we have discussed, there are four characteristics of the Barters along with dehydration and hypotension, presence of deafness, hypercalciuria, NSAID responsiveness, and polyhydramnios are typical of the Bartter syndrome, can be used to differentiate from other channelopathies. Very good. So everybody is on the right track. Number 3. When a 25-year-old male presents to the ENT clinic with the sensory neural hearing loss. So that is the primary point here. Patient also has got a normal blood pressure is present, but there is a history of recurrent loin pain in the past with the hematuria. Recurrent loin pain in the past with the hematuria. So why I have kept this question? Because very good. So Dr. Divya, Dr. MS are typing those answers. That is why I have kept this question. So whenever a patient you get the differential diagnosis, when the patient is having renal failure, that is elevated creatinine, elevated serum creatinine plus deafness, elevated creatinine plus deafness, we have to think of the two typical differential diagnosis. The two differential diagnosis, again, two differential diagnosis include, as some of you mark, are the Alport's syndrome, which is much more common. Alport's syndrome, which is much more common as compared to the Barter's syndrome. As compared to the Barter's syndrome. Definitely, Alport's is a much more famous disease. But when you compare, Alport's is a defect in the alpha 5 subunit of the type 4 collagen. It is a defect in the alpha 5 subunit of the type 4 collagen, leading to development of glomerulonephritis, which come with the dysmorphic RBC. It can also present with the deafness, can be present, and the patient can have lens defect in the diagnosis. It is the clinical triad of the symptom. I'll tell you, Barter's, as discussed above, is an inherited channelopathy, autosomal recessive, inhibitory defect of the sodium, potassium, 2-chloride ATPase pump. As discussed, this patient can present with the dehydration, but some patient may be normal BP also. So as I was discussing in class, that don't think that what we are reading is the majority. In exam, especially in INICET, atypical presentation are asked in order to create a confusion. But it is the presence of recurrent renal calculi leading to the loin pain. Recurrent symptom, recurrent calculi leading to the loin pain, which is one of the important point. And because it is due to that, it is going to be eumorphic RBC in the urine. Eumorphic RBC in the urine, presence of the problem. That is why more likely it is likely to be a case of the Barter's syndrome. Likely to be Barter's syndrome. Yes. So that is why, because Alport's syndrome, what we call this? Alport syndrome is called the most common glomerular defect causing deafness, while Barter's syndrome is the most common tubular defect causing deafness. So whenever you get a question of the deafness, whenever patient has got deafness, you must think of both of them. But most common glomerular defect, where there will be dysmorphic hematuria, along with that, there will be lens defect also. Then you will choose the answer as the Alport syndrome. However, here that being absent and the patient having recurrent renal stone symptom and eumorphic RPC, likely to have the correct answer. So, as I just told Dr. MS, that low BP is not. In the notes also we have written, there is more chance of low blood pressure in majority. While teaching also 10 times I have repeated that dehydration is going to occur. There are looking if more detail, there are 6 genetic subtypes of Barrter, out of which 4 are severe, 1 is moderate, 1 is mild. So hypotension need not be present. So what I told, it can be low in majority, but we have to look at other factors also. Like that, if you go to see, if you must say that the glomerulonephritis also must come with hypertension, then nephritic syndrome should come with hypertension. That also we'll have to consider, right? So we have to look at all the factor and we are choosing the best single answer. Glomerulonephritis में CKD के तरफ जाएगा. Then you are likely to develop the features of hypertension in the patient with Alport syndrome, right? So yes, always open to discussion because that is how we learn. Chalo. So match the clinical feature with the probable site of the renal disorder. In INICET, you can expect a clinical question. Of course, in the nephrology and rheumatology, the clinical signs are little less. But in neurology, paper में भर के, the clinical signs are asked. In ABG questions, ECG questions are more expected in INICET. So here we have the concentrated oliguria suggesting of the pre-renal AKI, the dilute polyuria suggesting of the tubulo-interstitial disorder, hematuria with hypertension suggesting glomerulonephritis, and the loin pain favoring obstructive uropathy will be the correct answer. So we have got the 1D, 2C, 3B, 4A, option number C. So I'm sure everybody got it right. So this question is a clinical based on symptomatology of the renal disorder that we can expect. Match the urinary cast with the probable diagnosis. So interpretation related questions are also expected. We studied hyaline cast, which is the most benign cast, is going to be most common finding in the urine, is also the most benign cast in the urine. The presence of muddy brown cast is specific for the acute tubular necrosis. The presence of broad waxy cast is considered worst finding, but it is seen only in the advanced CKD. And the presence of RBC cast in the urine is specific for acute glomerulonephritis. So again, we have A4, that is 1, 4, A4, B3, C1 and D2. Option number A. Great. So concentrated नहीं होता. Dr. Harshita, most of the time, good question you have to ask. In the glomerulonephritis, due to reduction in GFR, you can get reduced urine output. But concentration is not the problem. But the concentration will not be the problem. No concentration defect. Rather, in many of the time, clinically speaking, in most of the time, when patient has glomerular damage, there is also some secondary damage to the tubular function, which causes dilution of the urine. So because of reduced GFR, urine output may be low, but concentration is not the problem. And that is why not the correct answer. Correct answer is option number A, right? So take it forward. Which one of the following statement regarding the anemia of chronic kidney disease is false? What of the following statement regarding anemia of CKD is false? Erythropoietin deficiency is the most common cause. That is a true statement. Defective utilization also can cause. That is true statement because of increased bound state of iron. Due to increased bound state of iron, there can be defective utilization also. The transferrin saturation is an acute marker of iron stores in the patient with chronic kidney disease. I'll come back to that. But erythropoietin should be started only when the transferrin saturation is more than 20%. Erythropoietin should be started when transferrin saturation is more than 20%. So one important concept to discuss, that what is the best parameter of the iron stores? If I ask you, what is the best parameter of the iron store in the clinical practice? In the hematology based question, the best single answer can be serum ferritin levels. The ferritin levels are the best parameter in all except for the CKD. Except in the CKD, where the best parameter is the transferrin saturation. Except is the transferrin saturation. Correct? So single best answer would be ferritin level, except in the chronic kidney disease. Because serum ferritin, being an acute phase reactant, it also being an acute phase reactant, can be falsely elevated in the patient with CKD, and that is why it is not reliable. So for the iron store, we are going to look at the serum transferrin saturation. If the transferrin saturation is going to be less than 20%, then you want to start the patient on IV iron replacement. If the patient has got a transferrin saturation more than 20%, you are ready to start the patient on erythropoietin therapy. Right? So totally we have got the concept is important here. So yes, anemia of CKD, we have studied the flow chart. There are many causes of erythropoietin failure also, which we have discussed in the class. Moving forward to the next question. Which of the following are the features of autosomal dominant polycystic kidney disease? So AD, PKD, we have also said, are only the adult forms of PKD. They are going to be adult forms of the PKD because recessive form never survive till the adult. The recessive form never survive till the adulthood. So in this patient, what are the correct answer? True statement we want. The cyst can occur in the liver, the pancreas and the arachnoid is a true statement. Most common defect is the polycystin 1, also the true statement. The clinical manifestations are both renal and extrarenal, and mildest defect is the polycystin 2 on chromosome number 4. So yes, everybody got it right. All statements are correct regarding to the disease. We are familiar among the renal manifestation and the extrarenal manifestation. The most common renal manifestation is the recurrent loin pain, which can occur along with the fever or hematuria. This symptom occur because the cysts in the urine, the cysts are filled with urine. The cysts in the kidney are filled with urine and hence they are prone to infection. Hence they are prone to infection. But along with the renal symptom, the most common extrarenal symptom is the obstructive jaundice. The most common extrarenal symptom is the obstructive jaundice due to the compression of due to the IHBR compression by the hepatic cyst. Due to the IHBR compression by the hepatic cyst. So intrahepatic biliary radicals are compressed, leading to obstructive jaundice. So do you have to remember diagnostic criteria? I think the answer is yes, because from the ultrasound criteria. If you look at the diagnosis, ultrasound criteria, cysts have to be present bilateral. Unilateral cyst can be purely degenerative, age-related also. So go refer to radiology notes for the diagnostic criteria for ADPKD. Yes, that is right, important. So when a 60-year-old female with the ischemic cardiomyopathy comes with the chronic heart failure, complaining of the nausea and vomiting. So we know that the heart failure due to chronic heart failure due to ischemic cardiomyopathy can lead to the complications. What can they come? Along with that, the patient has got the uremic feature in the GI tract. Uremic feature of the GI tract and the elevated serum creatinine is present. So we know the problem is present. But out of the problem, the chronic renal failure can also lead to the pre-renal AKI, while the prolonged chronic hypoperfusion can also end up with the acute tubular necrosis. So this is an indirect way of asking how to differentiate between the pre-renal and the acute tubular necrosis. When the risk factor are the same, it is important for you to highlight the differences between the two. In this patient, if you look at the urea to creatinine ratio, here in the given MCQ 25/2, it is only 12.5. That is normal. The ratio is normal. While in pre-renal, it should have been more than 20:1. Second, if you look at the urinary sodium concentration, maximum sodium is reabsorbed. So it should have been less than 20 milliequivalent. While due to loss of concentration, it is more than 40 milliequivalent. But it is the FENA which is the most sensitive parameter. FENA which is the most sensitive parameter. When pre-renal, it will be less than 1%, while presence of more than 4% is typical of the acute tubular necrosis. Is typical of the disease acute tubular necrosis. And that is why the correct answer in this question is option number B. The correct answer is option number B is the correct answer. Done? Very good. So indirectly we are studying what is the differentiating table. We have discussed in notes. Now we are learning to apply that information in a clinical format to get the question answer. So when a 25-year-old smoker presented to the clinic with cough and the hemoptysis, so patient has got pulmonary involvement. Along with that, patient also has dysmorphic hematuria. So patient has got renal involvement also. and that is why we call them part of the pulmonary renal syndromes. Patient has presented with the pulmonary renal syndrome. Patient has come to us with. In this patient with pulmonary renal syndrome, the creatinine value is high. Both ANA and ANCA are positive. So that's why we said serology inconclusive. But immunofluorescence study indicates linear immunoglobulin deposits, which are gold standard for diagnosis of good pasture disease. They are diagnostic of gold standard for the diagnosis of the good pasture disease. So post-streptococcal is not a pulmonary renal syndrome. First, that is gone. So can ANCA be? ANCA is relatively non-specific. So sometimes patient with good pasture, 20% patient can be both. So as discussed in class, when the serology is inconclusive, since both are positive, you go for the renal biopsy to confirm the diagnosis. In the Wegener's granulomatosis, you expected the posse-immune pattern. You expected the posse-immune deposit in both Wegener and the microscopic polyangiitis. So linear biopsy is 100% specific for diagnosis of the good pasture syndrome. Yes. So question number 10, assertion and reason. Microalbuminuria is a sensitive marker of diabetic nephropathy. 100% true. It is an early finding. But is it because of the fact that diabetes predisposes to atherosclerosis, leading to renal artery stenosis? Answer, this is also true, but it is a cause of the macrovascular complications. It is a cause of macrovascular complications. So microalbuminuria is due to the microvascular complication. Is the microvascular complication of the diabetes. So we can say that both are correct. They are both correct, but it is not the right explanation for the assertion. Both are correct, but not the right explanation for the assertion. That is right. So complete. Everybody will help me. Dr. Himanshi is asking. Dr. Himanshi is asking that what are the conditions under pulmonary renal syndrome? Under pulmonary renal syndrome, there are, remember, total 5 causes of pulmonary renal syndrome. There are total 5 causes. One of them, the first one, is the good pastures syndrome. It can also be the Wegener's granulomatosis, can be microscopic polyangiitis, can be the Church-Strauss syndrome, and can be the HSP. Least common rare cause can be the HSP, henox-lon purpura, which is also known as the anaphylactoid purpura, will be the correct answer here. So under pulmonary renal syndrome, total 5 causes are there, which we have enumerated. The first one, good pasture, is the unique one, only 2 organ. Rest are all vasculitis syndrome, HSP being ANCA negative, others being ANCA positive. We will be able to differentiate between them. Very good. Correct answer. All of you got it right. Okay, moving forward. So, in which of the monoclonal antibody against interferon receptor has been approved for management of SLE? So, it is very, very important for you to know about the various biologicals in rheumatology. that is monoclonal antibody used in the patient with rheumatology. Very, very important. So which are the biologicals? Let us start from the top. So we will identify mechanism of action, and then accordingly you can tell me their indications also. Okay? You can tell me indications also. So first let us mark correct answer. Interferon receptor antibody is the anifrolumab. It is the anifrolumab newly approved for management of SL. The rituximab is a CD20 antibody. CD20 antibody. It is approved for management of the B-cell lymphoma, approved for SLE, approved for rheumatoid arthritis also. The rituximab is an anti-CD20 approved for lymphoma, SLE and RA also. The belimumab is an anti-BAFF, B-cell activation factor, or the BLYS, approved for SLE patient. Adalimumab. Adalimumab is an anti-TNF alpha agent approved for anti-TNF alpha agent approved for the rheumatoid arthritis also, and inflammatory bowel disease also. You have studied inflammatory bowel disease. Anifrolumab has got newly the anti-interferon type 1 receptor antibody. The anti-interferon type 1 receptor antibody approved for the SLE patient. Approved in the patient with SLE. So further, if I can give you some more for you to think about. So if I add in this agent anakinra, we have got tocilizumab. Tocilizumab. We have got tocilizumab also there. And one odd man I will add for you. Canakinumab. Canakinumab. Chalo, help me fill up the column now. Anakinra is the it is the interleukin 1 antagonist. Very good. The tocilizumab is the interleukin 6 antagonist. Okay, fine. So both of them, anakinra, tocilizumab, approved for rheumatoid arthritis patient. Yes, approved for the rheumatoid arthritis patient. And anakinra also approved for which patient? You can use it in the refractory patient with the FMF also. Familial Mediterranean fever, familial Hibernian fever. So auto-inflammatory disease. Also, anakinra can be given. Tocilizumab, of course, interleukin 6 antagonist we gave during COVID crisis also. So I want you to tell me, chalo last wala bataiye, what is the role of canakinumab? Where did you study? Canakinumab is the monoclonal antibody against interleukin 1 beta. Interleukin 1 beta approved for the management of acute gout, and also the only biological approved for the heart failure prevention. Only biological approved for the heart failure prevention is the canakinumab. Heart failure prevention and the acute gout, we can give it in the patient. So monoclonal antibody, because they are derived from live cell culture, they are called as the biological live cell culture. And in that, we have got multiple uses for them. Chalo, take it forward then. So match the following clinical feature with the palliative treatment options in the systemic sclerosis. Palliative treatment option. We said systemic sclerosis, the treatment depended upon the management of the organ involved. For the skin fibrosis, I would like to give anti-fibrotic agent, the D-penicillamine. We can give the anti-fibrotic agent, D-penicillamine. For the lung involvement, we can give steroid, NSIP, response to steroid. For the pulmonary hypertension, which is dreaded complication, we can consider the use of iloprost, and Raynaud's can be managed with the calcium channel blocker. So correct answer is option number C. Correct answer is the option number C. So in the systemic sclerosis, we know the treatment depends upon the symptom and on the organ involvement, right? Very good. Correct answer. Chalo. Arrange in chronology the stages of rheumatoid arthritis. So we have drawn the picture here. In the normal joint, what does the normal joint consist of? The normal appendicular joint consists of the synovial membrane, cartilage end plate, and the bone itself. So the normal joint consists of the synovial membrane. It consists of the cartilage end plate, synovial membrane. We have got the cartilage end plate, and it consists of the bone itself. Together, they constitute normal joint. But the stages of rheumatoid arthritis, the primary involvement, first site affected, is the synovitis. The primary site affected is the synovitis, is the first site to be affected. So we will put here, the first one will be D, that is synovitis. If left untreated, patient develop erosion of the cartilage end plate leading to pannus formation. If still left untreated, patient can develop areas of the bone erosions. Patient can develop areas of bone erosion, which finally leads to the irreversible deformity, which is characteristic of the arthritis group of disorder. So starting with D, it will go on to A, go on to the C, and go on to the B. DACB. That is option number D. So it will grow progressively. Synovitis, pannus formation, bone erosion, and irreversible deformity can occur in this patient. Right? Perfect answer. So kahan aap log ne miss kiya? I'm waiting to know that. Because few one of you mentioned 12 out of 15 मिला है. I'm hoping बाकी लोगों का score भी similar है, ज़्यादा है. So you can put up your score. So we'll know how you are doing. Match the organism associated with the risk. Yes, Dr. Imanshi, with cartilage erosion. Match the following organism with the risk of autoimmune disease. Very important. Most autoimmune disease are idiopathic in nature. So we want to match the following. Today I have included more match the following, maybe more than the exam, because I wanted us to cover more topics. So in the last minute yield, if I give you specific to specific, then we may miss. So let us try to enhance, more lateral thinking. So very good. I'm happy. You are doing good. So 10, 11, very good. So important is to realize the mistake. देखो सिली मिस्टेक ही हमारा रैंक खींचता है. It is not that we are not knowing, but silly mistake, which we can avoid. So it is the Epstein-Barr virus associated with SLE. Epstein-Barr virus is associated with SLE. Mycoplasma associated with rheumatoid arthritis. The chlamydia, we know, most common in the reactive arthritis. Most common organism in the reactive arthritis. And parvo B19 seen with the systemic sclerosis. Seen with the systemic sclerosis. That is number C. So what else is there here? Let us see. Ankylosing spondylitis. Ankylosing spondylitis associated with the Klebsiella infection. Associated with risk of Klebsiella infection. There is no association for psoriatic arthropathy. But if you look at which infection, the infection which can mimic the Sika syndrome and the infection which increases the relapse risk in the patient with vaginals. Chalo, 2 extra question leta हूं. So, relation of the infection to autoimmune disease. Relation of the infection to autoimmune disease. We must know. Which autoimmune disease mimics Zika by having the gland involvement? Gland involvement also can occur. We discussed in the triple H, HIV, hepatitis B, and hepatitis C. So tell me, which organism in the patient with vaginal increases the risk of relapse? And that is why we say that the vaginal is the only anti-autoimmune disease where antibiotics play important role, decrease the risk of relapse. All other, you have to maintain immunosuppression. But in vaginal, which infection, if you tell me, you will get the answer. Which infection in vaginal? I'm waiting. Not CMV, not HIV. What is it? It is the nasal carrier of the staphylococcus. Nasal carrier of the staphylococcus are the important risk for development of relapse. Correct. Dr. Divya has got the staphylococcus, which can be eradicated by giving antibiotic therapy. That is why it is the only autoimmune disease where antibiotic has a role to reduce risk of relapse. That is right. It has reduced risk of the relapse. So tell me, the most specific, last one, the most specific cutaneous feature in the polyarteritis nodosa will be most specific cutaneous feature in polyarteritis nodosa will be the libido changes, the skin mottling, which occurs due to the small arteries, medium arteries supplying the cutaneous tissue, libido changes. So point remember, the most specific cutaneous feature in the patient with the systemic sclerosis. In the patient with the systemic sclerosis is the shortening of the digit. Is the shortening of the digit. There is no role of scleroderma much, but most specific cutaneous feature in the patient with SLE is the malar rash, followed by the discoid rash. Specific cutaneous feature which can help in the diagnosis. You want to look at SLE rash, systemic sclerosis, and we got the polyarteritis nodosa. Polyarteritis nodosa comes with the libido changes, right? So please remember the dictum I always tell, because all of you have seen it today in real time. What I say that in the exam, it is not the one who knows everything who gets the top rank. The top rankers are the ones who are not going to make any unforced mirrors, who are going to avoid any silly mistake. Because trust me, every single student is trying their best to get the top rank, trying their best to get a good rank. And you must have a healthy competition. ऐसा नहीं होना चाहिए कि हमारा रैंक अच्छा हो ताकि दूसरे लोग गिरे, हमारा रैंक अच्छा हो ताकि हम अच्छा करें. So it is important for us to just look at that. Just don't worry. Just be aram se. Don't make silly mistake. That see, most of the time when we walk out of the exam hall, we realize, अरे यार ये मेरे को पता था. That is why. What is why? What is important? Practice, practice, and practice is most important. The practice is most important, and that too in an exam simulated setting. In an exam simulated setting, it is very important to practice. So whenever CBT are organized, please take opportunity. Please take opportunity because you need to have a real time experience, and that will make your efficiency better. And last, for students who don't have, so my email ID for any doubt in medicine, you can email me so we can try to solve them. So all my best wishes always with you. And I always wish that my students become better than me, because that is the whole primary, goal of the teacher. We want you to become better than us. We want to teach you already what we learned with 20 years of experience. And we want you to step further and go ahead by more and more years. Chalo. All the very best. See you on the other side as colleagues and not student and teacher, but as colleagues. Chalo. Bye bye.